Good morning, everyone. My name is Ishita Pandey, and I teach modern South Asian history and the history of medicine here at Queen's in the Department of History. It is my immense pleasure to welcome all of you to the first talk in the History Department seminar series this term. Let me begin by acknowledging that Queen's occupies traditional Anishinaabe and Haudenosaunee territory. I am grateful to live as an uninvited guest on these lands and to learn from the wisdom of those members of these communities who, in a recent statement, urge us to recognize the ongoing histories of colonial violence unfolding, and I quote them, here in Turtle Island and abroad, including in Palestine. Our speaker, Professor Ahmed Regab, is a historian, physician, and a documentary filmmaker. He is Associate Professor of Medicine at the Johns Hopkins School of Medicine and the founding director of the Independent Center for Black, Brown, and Queer Studies. As we were sharing anecdotes about graduate school last night over dinner, and we were talking about the joys and woes of grad school, I learned that our experiences had differed considerably. Because while I was complaining to my peers about the scrawling longhand in which colonial officials were writing in the 19th century, Professor Regab was continuing to practice as a physician in Cairo while he was completing his PhD in Paris. So it is this ability to be in many places that comes across in Professor Regab's prolific research output and varied interests. His work focuses on the history of medicine in the pre-modern Middle East and the Islamic world, as well as colonial and post-colonial medicine, science, and technology. He has published on gender and sexuality in the medieval and early modern Middle East, in post-colonial studies of medicine, science, and religion, and other questions about medicine, science, and religion in a diverse set of journals that include several articles in ISIS, Osiris, Journal of the History of Sexuality, the Journal of Postcolonial Studies, and the Journal of Islamic and Muslim Societies. He's also the author of 3 books, The Medieval Islamic Hospital, Medicine, Religion, and Charity, published by Cambridge in 2015, Piety and Patienthood in Medieval Islam, published in 2018, and Medicine and Religion in the Life of an Ottoman Sheikh, published in 2019. Beyond this impressive record of publication, Dr. Regab generously serves the scholarly community in various capacities. He's on the Council of the History of Science Society, is a member of the editorial board of the Bulletin of History of Medicine and of ISIS, which is the Journal of the History of Science Society. He's also the co-editor of Osiris, and he edits the Johns Hopkins University Press book series titled Global Studies in Medicines, Science, Race, and Civilization. He is currently involved in over a dozen collaborative projects, which sort of blew me away when I read that on your CV. And these range from one on physicians and medical practices in 19th century colonial Middle East to something as vast as the history of science. It's fabulous to have you here. Professor Regab is currently working on 2 new book projects, and this is another thing that I was wondering, how do you work on 2 books at the same time? The first, Communities of Knowledge, Science in Medieval Europe and Islamdom, is under contract with Princeton University Press, and it looks at the history of medieval and early modern science across traditional boundaries separating Europe and the Islamic world. The second book, Around the Clock, Time in Medieval Islamic Clinical Cultures, is under contract with Johns Hopkins University Press. And the talk that we are listening to today is one of the chapters from that book and is entitled Sex Time, Relatedness, and the Sexed Body in Medieval Islamic Medicine. Please join me in welcoming Professor Regab.
Shida, thank you so much for this very generous introduction. And to be fair, longhand of colonial officials is really difficult. thank you all for coming, and it's such a pleasure to be here, and I'm very delighted to share this. Again, this is part of a book project. I'll talk a little bit about what the book is about overall. So I'm excited to hear your thoughts and your questions. I'm going to start a little outside of the chapter itself with executive order that was signed by Donald Trump on January 20th, on the very first day of immediately after his inauguration. The formal title is Defending Women from Gender Ideology Extremism and Restoring Biological Truth to the Federal Government. This is the executive order that provides, for the first time in history, a definition that the American government is given of what are sexes and genders. No genders, by the way, just sexes. And that there are two sexes. One produces the larger gamete and the other produces the smaller gamete. They are both defined at conception, despite the fact that nobody produces gametes at conception, and that there are so many humans that do not produce gametes at all. So, a warning, this talk is part of the gender ideology as defined by the government. But the reason I'm starting here is because of what I see as a responsibility for us as historians, particularly historians working not only in the modern period, but also in the medieval and pre-modern period, to make sure that we don't slide into what we can call agnotology, and then a forced or an intentional ignorance of the fact that the binary system, the two sexes, is a relatively new system that is and that has been connected to biological reality only for about 2 or 2.5 centuries. So yes, a world without trans people has never existed and never will. And so in a way, this talk and a lot of the work that many of us are doing in relation to gender and sexuality, particularly in the pre-modern world, intends to clarify the idea that this notion of different sexes and different genders has existed throughout the world for a very, very long time and continues to exist as well. This is not to say that we cannot escape our history and do something that is completely different. We don't have to be always doing what has existed for hundreds and hundreds of years, but it is also important to fight against the assumption that the world has been living in a bilary system forever, and it's only this new gender ideology that starts to change that. Shifting gears a little, this is just to give you a background on the overall book that this chapter comes from. This is a book around time and temporality in medieval Islamic clinical culture. Anybody who's studying pre-modern history of medicine will encounter Hippocrates' first aphorism, life is short and art is long, which starts, and it is supposed to be the very first thing that a medical student learns ever. You start with the Hippocratic aphorisms, and this is the very first sentence that you read in your medical education, which immediately puts to the forefront of any medical practitioner the importance of time management, but also the role that time plays in medical practice. The book investigates a variety of expressions and questions of time. It starts from understanding deep time, how physicians in the medieval world thought about the history of their own practice and the development of medicine. Then we talk about the tools and words of time, how did people actually measure time? And then it goes through a kind of a variety of expressions of time, from years and seasons to childhood and aging, to the gendered body, which we will be talking about today, to diseases, acute and chronic diseases, to time and piety and manners and how you use your time, and to the idea of time and place, how time happens in a variety of spaces that doctors practice in, such as hospitals, courts, and markets. In the title and throughout the talk, I'm using the word clinical in a very literal meaning as bedside. And although medicine is practiced and has been practiced in many cases away from the bedside, as if you will, I argue in a lot of my writings that the bedside practice remained a paradigmatic practice in the history of medicine in the Islamic world, and really in the Galenic sphere anyway. The ideal place of the physician is exactly what we're looking at here. The patient is lying down, completely under the control of the physician, and the physician standing or sitting beside them and practicing their medicine. It is not a secret, or it's not a surprise that you'll see a lot of the illustrations, whether from the Middle East or from Europe. It's always, or most of them are portraying this particular picture, the idea of the bedside. In my book on piety, I argued that the bedside metaphor crosses from medicine to also religious and pious practice, whereby the divine in general, or the prophet, for example, becomes the physician that is also at the bedside of the sick. And in this case, the sick is all of us and our sins. So clinical here is not connected to our understanding of clinical medicine, but it is connected to this paradigmatic nature of medicine as it connects to the bedside. Today I'm going to talk about these things, and I promise I'll finish quickly, or I hope so. I want to start by talking about what is really the point of sex and gender. And I'll explain what I mean by this in a little bit. And then we'll talk about the medical making of sexes. This is a kind of an introduction to understand how these physicians, how many sexes they encountered and they thought they encountered in the human body. Then two particular features of the time in relation to sex and gender, the question of belatedness, or late bodies, if you will, and the question of periodicity and cycles. And finally, I'll come back to the original question, which is what do we do, or by understanding sex and gender. The question of what is the point of sex and gender starts from the assumption that there are so many things that we can know about humans that some of them are necessary for particular situations and many of them are not. There is very little, one could argue for every piece of information that we try to glean about a particular person, we normally have a reason for why we want this particular knowledge. In the case of medicine, medicine is a practical art. These physicians are writing, yes, but most of the writings that we analyze right now is essentially, quote unquote, their side hustle, if you will. Their main activity, the vast majority of them, is to encounter patients and to treat them. So in this case, there comes an important question, which is what do you do with knowledge? This is a question that they themselves keep asking all the time. You need, for example, when you're sitting by the bedside of a patient, they would argue, especially if this patient is not educated, you need to shut your ears when they are talking about things that are not important. You need to ask them very specific questions so that you get very specific answers that would help you diagnose and treat them. The rest of the information is unimportant. So the question from them, but also to us, what is the point? Why do we need to learn about sex and gender? I would argue that in large parts, we can figure out the answer to this question through the connections between sex and gender and other performances. In other words, if we see how sex and gender is used, we can understand why we need to learn about it. And the key answer in society is related to power. In this particular illustration, for example, where a white woman slave owner is reprimanding a slave woman and a slave girl because they didn't bleach her clothes properly, we can see here that although technically and according to the executive order, they belong to the same sex and gender, they really do not though. The rules and regulations that apply to one of them certainly does not apply to the other. In other words, I would argue that sex and gender in society overall, and this is not a surprising argument for it's building on feminist studies for decades, it's related to a particular performance of power. In relation to medicine, I will continue to ask this question, why are these physicians, why do they need to know? And this will allow us to understand how they end up simplifying in a variety of ways the reality of human bodies and the reality of human lives into a specific knowledge system that allows them to do specific things that they want to do. In other words, knowledge in general in the practice of medicine is not important. Useful knowledge is the key thing. And part of understanding what they are doing and how we can think about sex and gender is to ask, why do they need to know? Like I said, I'll come back to this, but it will also be a theme that we will discuss throughout. In thinking about the making of sex and gender, one of the key texts that a lot of us read and we continue to teach and has been extremely influential in thinking about sex and gender in the pre-modern world is Thomas Laqueur, Making Sex, Body, and Gender from the Greeks to Freud. This was published in 1990, and it provided, now of course the historians in the room, once you hear from the Greeks to Freud, you get like an itch. So resist the feeling that you can't write a small book about all this. That's not the point right now. The book offered an interesting proposition that for thousands of years it had been a commonplace that women had the same genitals as men, except that theirs are inside the body and not outside. In this world, the vagina is imagined as the interior penis, the labia is the foreskin, the uterus as scrotum, the ovaries as testicles, etc. And therefore, Laqueur offers the idea that in the pre-modern world, there were no two sexes, but only one sex. And this one sex has the exact same organization of organs, but it just represented differently. He relied primarily on Galen on the use of parts, and where Galen is doing exactly this kind of comparison and telling us, how you can see these specific things. And this is on the images from Vesalius. And although when you look at it, it looks very much like a penis, this is actually the uterus. So all of this is the outside of the vagina ending with the uterus that is cut sexually. Now, obviously, this presentation, Laqueur argues, shows how this, the Galenic view about the two sexes being essentially one sex is also represented in this literature. Or in these illustrations. A lot of scholars have criticized Laqueur's way of explaining the one-sex model. Catherine Park, for example, Joan Caden, Helen King, a lot of other people. And many of them are Europeanists or European historians, and they argued that there are two main areas that are problematic in this assumption. One is that Galen's On the Use of Parts was not that well known in medieval Europe. While it was known in the Islamic world, it was actually translated and spread in Europe quite later, and therefore it is very hard to argue that this particular book of Galen could be the basis in the medieval world. The argument could be made possibly about the early modern period, but definitely not on the medieval period. More importantly, the particular quotes that he presents from Galen are themselves not as widely recognized or discussed. And how do we know this? We know this from commentaries. Commentaries are not commenting on this particular area. They are not explaining it, and therefore, even if it exists, it doesn't necessarily mean that people paid that much attention to it. Now, if we move to the Islamic world, things are going to be a little dicier, if you will. On one hand, On the Use of Parts was a very well-known book. It was translated to Arabic very early on. All the physicians read it. On the other hand, there is actually a wealth of commentary and explanation, and even independent writings that use very similar narratives. So, for example, Ibn Sina in Al-Qanun, or the Canon, argues and the uterus is similar to the tools of reproduction in males, which is the penis and what accompanies it. However, one is complete and directed outwards, and the other is incomplete and trapped inside. And he goes in again and explains the details. Now, he shifts a little bit from Galen in the sense that he doesn't think that the scrotum is the uterus, because a lot of these scholars actually argue that the uterus is really anatomically is similar to a bladder, because it is a muscular organ while the scrotum is skin. So he puts the scrotum as the uterine peritoneum. Al-Majusi has a very similar thing. These organs in the males and females are one thing, but they differ in their shape and essence. The penis in the males is rectangular and hard. The neck of the uterus in women is short and soft. And he goes on to do this kind of comparison one-to-one. The big issue and the second question that a lot of the critics of Lacour argued, and that applies in this context, is that he misses the idea of organ homologies. The notion that actually all of these physicians did believe that the human body is ultimately the same. But the differences that they explain are actually pretty big. And the question, again, is why do you need to know the differences and how do these differences occur? When we see this, we start to see a very different understanding of these texts. On one hand, in the Islamic world, it's very clear for all of these physicians that the uterus does not have a homology in the male body. A lot of them describe the uterus as a second bladder. There is also a wealth of Galenic literature around the disease known as uterine suffocation, which I'll talk about in a little bit. Now, Muslim physicians argue the whole idea of a wandering uterus, that the uterus just leaves its place and keeps moving around inside the woman's body, is impossible. They explain that we can see ligaments, it's attached, it doesn't move, but the disease can be explained differently. But this is to keep in mind that from the get-go, there is an organ that just exists in one types of bodies, but doesn't exist in the others. The other important thing, though, is that the uterus, the vagina, or the penis is not the way that they thought sex differences can be fully understood. In other words, while our modern understanding of sexes relies on the 0 and 1, the existence or the lack thereof of a penis, for example, their understanding is related to the continuum of size. The different sizes of penis, and in this case, you can think of the clitoris as at one end and a huge penis at the other. All of these represent a variety of sexes and a move on the sex continuum. And in this case, the big question is, why are the testicles, for example, outside, and the ovaries, which are at the time in Arabic used to be called with the same word, and the ovaries are inside? This is the medical question. When we look at the writings, Majusi himself describes the formation of the fetuses in a different way. He talks about how, so the question is, how does a male fetus or a female fetus develop? And the big question in the Galenic literature is about heat. Male bodies are hotter and drier than female bodies, but it's a lot more complicated than that. If seeds were the seeds as in the male and the female seeds, if the seeds were mostly hot, the fetus would be male. If they were mostly cold, the fetus would be female. It gets more complicated. At-Tabari, who is, by the way, a really important physician and was the teacher of Ar-Razi, the famous physician, a male right testicle seed to the uterine right horn produces a male. Why right? The right side of the body has the liver, and therefore the right side of the body is hotter than the left side of the body. So if the two seeds are coming from the two right sides, they are going to produce a male. But a left testicle seed to the uterine left horn will produce a female. A male right testicle seed to the left horn would produce a feminized male, and a male left testicle seed to the right horn would produce a masculinized female. Now, this gets even more complicated because heat in itself is not an on and off situation. It's a continuum. And heat is affected by a variety of things. It is affected by what you eat, by the weather, by what you're wearing, by whether you're tired or not. So for example, when these physicians follow from this to give particular advice for example, parents who are seeking to conceive a male child, they are telling you, eat spicy food, do not eat fish, milk is really bad, make sure that you sleep well, don't tire yourself, and be strong, and that will result for both males and for both parents, that will result in a male child, or at least enhance the chances for a male child. In other words, what we're looking at here is a continuum of sexes. This continuum has three anchoring points. On one end, we have males, what are described to be males of extreme masculinity, and these are basically produced by a very hot seed, male seed, and a very hot female seed implanted on the right side of the uterus. And on the other side, we have females of extreme femininity, which produce exactly the opposite, a very cold seed coming from the left side to another cold seed in the left side. And right in the middle, When all of these things are equal, we have what is described in medical literature as a true hermaphrodite. The true hermaphrodite is a person who have both organs, both of them exist at the same time, and both of them are functioning. Another layer is a person who does not have any functioning sexual organs at all, and they would argue that this also might be somewhere in the middle of the continuum. Much like in their experience, the true hermaphrodite is a very rare occurrence that very few physicians have ever encountered. They also believe that the extremes of the continuum are equally rare. The vast majority of humans are somewhere in the middle of this continuum. In other words, it is no longer a question of having a particularly or male or a female, but it's of where this person lies on the continuum. We come back again to the question, why does it matter to make this to know this, and could you actually diagnose it? You could not, the argument is in the vast majority of cases, you cannot actually diagnose it. You could only diagnose it when the patient is complaining of specific things. So you need to know this because, for example, a woman who comes to a physician complaining of amenorrhea or lack of menstrual cycles, this could be a disease that requires treatment, but it could also be a completely normal position because of where she is on this kind of what we would describe as the sex continuum. And therefore, in some cases, the physician would intervene and, for example, do a bloodletting or induce bleeding because the lack of menses will result in accumulation of wastes, and we'll talk about this in a little bit. But in other cases, they would just say, you're fine, it's not a problem at all, and therefore it is not an issue that she should worry about. And in these particular cases, for example, there's no direct link between menstrual cycle and its irregularity and fertility. And I'll talk about this at the end. In other cases, the morphology of the sexual organs might reflect, but it may not be a really clear predictor of how a person, for example, where they fit on the sexual continuum. More importantly, and this image illustrates this has really very little to do with the gender presentation. The gender presentation is connected rather to particular understandings of laws and regulations. And this is an image in a medical textbook of a midwife that is excising a penis from a female patient. And as you can see, the woman patient is fully veiled. She's clearly understood and functions in society as a woman. But in this particular case, she has a penis and she wants this penis to be fully removed. I'm going to shift now to think about more directly about the question of time and how the differences, if you will, in relation to sex and sex organization affect the reality, the day-to-day reality of medical practice. Now, remember, the sex continuum, as I mentioned, is ultimately a theory. It's a theoretical explanation of specific things, but it's not a thing that, somebody would go to a doctor and say, where do I fit on the continuum? And they would diagnose them that way. In order to understand the different temporality that the gendered body stands on, we got to go back to the main quality that these physicians believe defined the sexes and the performances of the sexes of different bodies, which is heat. Again, male bodies are perceived to be generally on the hotter side, and female bodies are perceived to be generally on the colder side. Now, a lot of these physicians, Al-Razi, for example, warns his students that this does not mean that any male is hotter than in complexion or in humors than any female. Because you could find females who have a complexion that is hotter than particular males. But in general, overall, the people who have the morphology of a male have hotter complexions than those who have the morphology of a female. But what is the morphology anyway? If it is not connected, as our modern medicine wants to tell us, to the morphology of genitals, what is it connected to? It is connected to a variety of things. It's connected to hair distribution, to muscle size, to height, to bone size, to mental capacity, to memory, to capacity of learning new ideas. It's connected to a whole host of things. All of them are actually related to heat. So for example, one of the ways that a hot body tries to remove excess wastes and remove excess heat is through hair. And that's why men, for example, or people on the male side of the continuum will have more facial hair because their body is expelling the heat from their bodies. It is also heat allows for muscles and bones to develop quicker, and therefore, on average, a male would be longer or taller in size and bigger in size because they have heat, more heat in their bodies. It is the heat that will force the testicles, the male testicles, outside the body so that they don't actually cook inside the body and destroy the seeds. While, for example, women do not have, or females who do not have testicles outside the body do not need to do that because simply their bodies is cold enough that would allow for the seed to develop. In the same way, heat affects mental capacity. And here again, we can see how this medical understanding of the body affects the social understanding of gender roles. So for example, a hotter brain allows a person to have a better memory. Why? Because the brain becomes more malleable and we remember things through impressions. So I remember that there is a table here because the form of the table is literally imprinted on my brain. But a softer brain, because it is hotter, allows for better imprinting and allows for people to remember more and more things. And so men are supposed to be people who will remember a lot of things better, will remember poetry, will be scholars, and will be physicians, of course. In the same way, a hotter brain can also lead to a lot of rash decisions. We still use the word hot-headedness till today to describe exactly the same idea, and this comes from Galenic medicine. Masculinized females, for example, who are supposed to be on the hotter side of the female continuum, if you will, these masculinized female could be recognized by the fact that they can be scholars, these physicians would argue. Many of them remember poetry. Many of them would tell jokes. And at the same time, they are really funny and they call darifat, which is literally translates into funny women. And then Al-Majusi tells us that you will find that these women actually do not really like to have sex with men. And if they have sex with men, in many cases, they will try to assume the male position, the traditional male position, and be on top, because this is all related to the heat of their body. And they might marry men that are normally colder in complexion just because they get attracted more to these men. The colder body means that there is a lot of issues that are related to the development. So if we go back to the fetal development, we can see that the colder body allows or develops a lot slower. So bodies that are closer to the female side, if you will, of the continuum, the fetuses develop much slower. They are probably a week to 10 days before the male fetuses. And the male fetuses are developing faster because the seed is really hot, and the hot seed allows it to develop much faster. So, for example, a lot of these physicians are trying to define or understand the different stages of pregnancy. There is a big controversy around how long does pregnancy last. For the physicians, so this is Al-Baladi, who's a physician who lived in Cairo in the 11th century. There are different opinions on the duration of pregnancy. What physicians believe is taken from the determinations made by pregnant women and their testimonies that they give birth in the 7th, 8th, 9th, and 10th months, and they calculate that every month is 30 days. He's saying that this is the opinion of physicians because philosophers disagree. Because philosophers did not agree that you could just have, what is 30 days? 30 days is not a month. It doesn't work this way. It has to be connected to a particular celestial organization. It has to be the 28 days of the lunar month. But if it is the 30 days of the solar month, then pregnancy should last for 12 months, not for 9. Why? So there's a lot of debate around why exactly this time. For physicians, that's really not important. What is important is we have patients, these patients give birth. There is no particular way of diagnosing pregnancy early on. And the only way of diagnosing pregnancy and knowing how long this pregnancy has lasted is actually to listen to these women who are saying, I've been pregnant for 7 months or 8 months or whatever number of months. And then he goes on to calculate these months in days, and they use these calculations to go back and to try to define the earliest stages of fetal development. Now, the earliest stages, to try to understand the different stages of fetal development, is important for two main reasons. One reason is related to abortion, which is allowed under Islamic law until ensoulment. So when does ensoulment occur? Now, for a lot of scholars, religious scholars, ensoulment occurs when quickening happens. So when you actually feel the fetus moving, this is when ensoulment happens. Before that, it doesn't happen. Other scholars, for example, argue that use a particular verse in the Quran which says that we created him in a different shape, him as the fetus, and gave him a soul. In saying that, if abortion happens and the fetus does not look fully like a human, then it has not been given a soul. Now, this is a post-diagnosis, right? So here it doesn't help with before the abortion happens, but it helps only after the abortion happens. I can talk more about abortion and the questions of legality later on. For physicians, it's also important because of the type of medications and the type of care that they would give, particularly to rich women who are able to consult physicians during their pregnancy and to consult and to ask what should we eat and when, etc. So they want to know when exactly are the different organs being developed. And so, for example, at the moment when the liver is being formed, the woman should eat liver, obviously, because that will help the liver formation. When there is a moment when the heart is being formed, you should eat a lot of blood, or blood-related things. So liver, heart, particular forms of drinks that have similarity to blood. So wine would be a good idea, but not a lot of it, because a lot of wine is a problem for pregnant women, these physicians argue. So they are really concerned with the development of the fetuses because they want to understand what should women eat when they are pregnant and what they should do, should they rest, etc. They are also concerned about the differential development of the male and the female fetuses because, again, this will result in very different care. And we're talking about when the difference is about 2 weeks, for example, that's a very long time in the course of a pregnancy. So if the male fetus is developing 2 weeks earlier, then the instructions that you're giving to the woman earlier to eat something or to eat something that will enhance the development has to be 2 weeks before, for example, a female fetus. And therefore, they start to develop new tools to understand whether a woman is pregnant with a male or a female. And again, heat comes back up. If Razi says, if you have a woman and you want to know, let her sit, but don't let her sit on a stool or a chair. Let her sit on the ground. And it will be difficult, but that's fine. Let her sit on the ground. And then once she sits and rests, ask her to stand up. If she leans to the right side, it's probably a male fetus. If she leans to the left side, it's a female fetus. Why? Because the male fetus is implanted on the right side of the uterus, and therefore there is a lot of weight on that side. So when she's starting to move, her weight will push her more to the right side. Now, you'll see a lot of discussion around the two horns of the uterus. Now, the human uterus doesn't have very well-developed horns, but at the same time, these physicians are comparing the human uterus with bovine uteruses. So cow uteruses have actual real two horns, and so they still use the same metaphor to describe the human uterus as two almost separate sides. The idea of belatedness and thinking about the female body as a body that has less heat, and therefore a body that is effectively late, coming a little later, allows us to see how medical knowledge at the time is defining a standard body. The standard body is not the female body. It's the body that came first. The male body is the standard body, and the female body is understood to have come late, rather than the male body coming early. In thinking about the standard body and a particular male body that represents the standard of Galenic and humoral medicine, We now understand a lot of the writings, and now we understand why, for example, there are specific literature around gynecology and there are no specific literature that describes, for example, male diseases. In other words, there is an understanding of the female body or bodies on the female side of the continuum as particular, as having differences, and therefore, from a physician's perspective, as potentially having problems. So, they are worried, for example, about chronic diseases. Chronic diseases are colder diseases than acute diseases. And therefore, they are saying that women normally are not able to continue or finish the disease over in an acute fashion, and therefore chronic diseases are more common in the female bodies than they are in the male bodies. In other words, in thinking about the temporality of development and how it connects to heat, or how the idea of heat, which is very much a theoretical idea that you cannot measure in any way, it's just a theory, how this whole idea of heat can translate into a temporal organization of the body, we can understand how a theoretical notion around sex differences can inform a particular diagnostic and therapeutic approach. The other big question that a lot of these bodies on the female side have is menstrual bleeding. And there is menstrual bleeding is connected, in their view, to also the question of heat. Anybody produces a number of wastes. These wastes needs to be, to use the term cooked, meaning completely ripened, and then afterwards the heat allows the body to expel these wastes in a variety of ways, including, like I said, hair, for example, nails, including sweat, urine, feces, etc., etc. Because the female body is understood to be colder, the result is it is not able to expel all the wastes that it produces through these normal fashions. And therefore, a lot of these wastes are accumulated, and they keep accumulating until they need to be almost a dramatic event of expelling a significant amount of waste at one time, which happens through menstrual bleeding. So, with this understanding of menstrual bleeding, the second question is, how do you differentiate menstrual bleeding from other forms of bleeding? Because the idea here is bleeding in general is not necessarily a good thing. So how do we differentiate between bleeding, as physicians, between bleeding that is normal, in fact, if it doesn't happen, it's a problem, and bleeding that is understood to be a disease or a problem? And here we encounter a variety of ways that these physicians are trying to devise to understand how to differentiate between menstrual bleeding and other forms of bleeding. One of them, Al-Razi, says that menstrual bleeding has a very different type of pain from other forms of bleeding that are caused by tumors or ulcers or hemorrhoids. And he's unable to really describe this particular type of pain. So after going around it in a variety of ways, saying in one book, actually menstrual bleeding comes with absolutely no pain, then coming later and say, no, sorry, hemorrhoids comes with absolutely no pain. There is pain with menstrual bleeding, my patients tell me. And then coming back and saying, well, but it's a different type of pain. But what is the pain? He ends up at, if you look at the kind of the development of his argument, he ends up by saying, women normally know if this is menstrual bleeding or not. So you should just ask them. There is also the idea that menstrual bleeding stops and starts. And therefore, in a lot of texts, for example, menstrual bleeding is described as a chronic bleeding. Chronic in the sense that chronic thing in medicine is defined in two ways. One, a disease that continues, that doesn't stop, or a disease that comes in bouts and ends, bouts and ends. And therefore, menstrual bleeding comes and stops. And therefore, bleeding that doesn't stop at all is either not menstrual bleeding or that there is a problem that is happening with menstrual bleeding. The one thing they never talk about is the thing that we consider to be very much part of the understanding of menstrual bleeding, which is in the word itself, that's related to a month or to a moon. For a lot of these physicians, menstrual bleeding does not have a particular schedule. It is periodic, but it does not have to be regular in any way. Sarah Verskin, in her really fantastic book about infertility, addresses this particular point because this becomes, she's working primarily with legal texts, and legal texts are interested in knowing when a divorced woman is allowed to remarry. And for a divorced woman to be allowed to remarry, she has to have 3 menstrual bleedings or wait for a year. So what if she doesn't menstruate, then she can just wait for a year. So how do they calculate 3 menstrual bleedings? And she's arguing that if we get outside of our modern medical bubble, the fact of the matter is a lot of women, the majority of women, particularly lower class women, married very, very early in life. There is a lot of very early pregnancies, and therefore that are very close to menarche and to the period where many women do not have regular periods, and therefore it becomes extremely difficult to get a stretch of time where there are regular periods that are observable by all of these male scholars that would then say that actually periods are regular. And therefore, you find a lot of these physicians saying, well, periods come every 40 days or 38 days or sometimes 50 days, but they normally have some kind of rhythm that differs from one woman to another, and every woman would tell you that these are the times that a particular period comes. I want to use this particular point to think more actively around the question of expertise. And this is what will take us to the next point, which is what is the point of sex and gender? For all of these physicians, the point of understanding sex and gender is related to 2 main issues. One, that it can serve as, in one way, as a diagnostic and therapeutic category, that this is a knowledge that helps in diagnosis and therapy, and on the other, that it is connected to particular gendered performances that are related to how the society is organized. What we see all the time is how these physicians are trying to work really, really hard to continue to hold on the level of expertise that they have on the rest of the body. But they're really unable to do that. So in many cases, they want to create theories that allow them to predict, to make the body, the medicalized body, a lot more predictable, a lot easier to diagnose and to treat, but particularly when it comes to the question of gender and the question of sex, they have to defer to the person, to the patient, and to ask a lot of questions. In thinking about women's medicine in particular, these physicians try to resist in the writings, but are ultimately faced with the reality that there is a level of knowledge and expertise that they simply do not have. And a lot of them will end up, despite all of the theoretical work, coming back to the idea of you need to ask the midwife and you need to ask the woman. In another chapter, the chapter on childhood, I talk about how this shifts immediately so part of this chapter is about pregnancy in particular, but once birth takes place, once labor happens, you see a complete shift and a complete change in how these physicians are talking about the female body. While the pregnant body ultimately can be cared for by physicians, but the timing of the care is something that these physicians are unable to determine. Again, they can't know exactly when pregnancy started. They can't calculate in any accurate way the days and the times since the pregnancy started, and therefore they have to listen to the woman and ask questions around, so what do you feel like eating? And they infer from that what are the things that she's missing and what the things that she needs to do. Do you think you were pregnant? And again, in the absence of a regular period, or the idea of a regular period, that also makes it again in the hands of the woman's experience. But once the child is born, it becomes a completely different thing. They write about how the wet nurse or the nursing mother has to be put on a particular regimen of food. She should not be allowed to eat this and this and this. Even if she doesn't like it, it doesn't matter. Suddenly, the expertise gets to be stripped out precisely because there is now another body that becomes the object of medical knowledge. And the woman expertise, which was very relevant and very important until yesterday, becomes completely irrelevant, if not entirely dangerous, in dealing with the child. The other side of this is that I'm bringing here 3 images that represent for us 3 different aspects of the dealing and the intersection of sex and gender. On the left side, we have a slave market. And here again, we have gendered bodies, but are dealt with in very different ways. The modesty rules do not apply in the same way. The relationship and between the different genders, gender segregation rules, all of these things do not apply in the same way at all. In the middle, we have a process, another surgery coming from the same textbook that I showed you. And this is another surgery of voluntary castration, where there is this patient wants to be castrated and is being castrated. And here again, there is a question around the fact that they do not believe that they want the penis anymore, and the penis is going to be removed. And this medical procedure becomes also a way of allowing them to change and move within the landscape of sexes and genders. And on the other side, this is from a little later manuscript, and it's a book of love poems, and these are 2 men. And in the majority of these love poems, the idea ultimately, the real love, this poet and many other poets argue, is really the love between 2 men. The love between a man and a woman, or between 2 women, is an approximation of the real love between 2 men. And here again, the gender performance is affected in a variety of ways by the wealth, the space, and the place. We'll stop here, and I'm sorry for going over time. Thank you all so much. Yeah, thank you so much for these questions. The humility is, they don't like it. So they have to be, because they don't have enough information, but they really don't like it. So they are always, and it's not only related to women overall. They just do not like the idea that they have to rely on the patients. And it takes a very, there is also a kind of a socioeconomic difference here. So they have a lot better, they are fine with listening to very rich clients and very learned clients, because the learned clients will talk in a language and will understand their diseases. But for example, in the hospital, where they treat very poor patients, they really hate listening to the patients and think the patients do not make any sense, but they have to. And in terms of the practical sources, yes, these are, and this is part of the argument. They do not mention a variety or significant number of cases. They mention cases or specific cases very rarely, but this is not about, this is related to, again, the understanding of the knowledge universals and particulars. Particular knowledge of particulars is not reliable. So giving you 1, 2, 10 cases is not important and doesn't help at all. But as a physician who've seen hundreds of patients, I'll just tell you what it is, right? And therefore, I will do the work of taking out all the exceptions and just delivering what I believe is the universal knowledge. And that's why they're not mentioning cases by name, except in very rare occasions. We do have evidence of many of the physicians, particularly the ones who practiced in hospitals, that they wrote collections of cases. Unfortunately, very few of these survive. But in their biographies, where there is a list of the books, many of them are saying, you have the titles of collections of cases. Now, the other part, how will they know the bodies? There is no dissection. And there is huge debates that has been going on in history of medicine around, was there dissection, was there not dissection? And for a long time, historians of Islamic medicine have argued that dissection is, that they did not perform dissection because it was religiously prohibited. There is, of course, religious prohibition against mutilation of bodies, but there is no single fatwa or legal opinion that says you cannot do it in case of medicine. But for the majority of them, there is just no need for it. Because on one hand, you already know what, they dissect animals all the time. Some of them even have stories about raising baboons and other monkeys to dissect them. So that happens all the time. But the key and the big issue is that living bodies and dead bodies are 2 different things. And that's actually, if we're thinking about there is a particular shift that happens with modern medicine when we suddenly believe that life doesn't really matter in terms of how the body functions. But for these physicians, why should I care if there are these tubes in there when I don't really know what the blood does inside of them as it goes? Why is this even important? And that is a story that comes all the way back to Galen, where Galen himself was very, very famous for vivisection of animals. And they do vivisection. So you try to dissect an animal while the animal is alive and try to go as deep as possible before the animal completely dies. But this is the real knowledge. The knowledge of a body that is dead is just, what do you actually do with that? Yes. These are great questions. Thank you. For the first one, you see more of this later on. So there is a change in how these books are written from, say, the 9th century into the 13th, 14th century, and in part because in the 9th and really, into the 13th century, the vast majority of these physicians are not Muslim. So they intentionally avoid talking about anything that is remotely religious. Ultimately, these books they are written for many of them are written for other physicians, but they are still books that are written with the support of patrons. All of them are Muslim rulers. And so there's very little discussion of religion, or they try to completely avoid it. Now, this is also something that, again, that is also inherited in a way, because the way back in antiquity, the Alexandrian rendering of Galen was also one that intentionally removed all religion from it, just scrubbed it clean so that it becomes monotheistic. So that happened to Galen before, and happened to Hippocrates as well, and to all of these ancient Greek authors, that they are receiving these works coming from Alexandria and coming from Constantinople, and they have been scrubbed out of all the gods and everything that's related to religion, and any mention of gods become singular, etc. And then any mention of Asclepius becomes a mention, the god of healing becomes a mention of saints. So when these are translated, there's very little religion in them already. And the only mentions are very little monotheistic mentions. The saints are translated into the ancients or the good doctors, or sometimes the saints. But, the model for the writing has been scrubbed clean of anything religious. And so early on, they are writing without really any references to religion. But later on, as more and more Muslim physicians are writing, and as also they become involved in other forms of professional activity, like, being a doctor, if you're not working in a court, being a doctor is not a profitable profession at all. So they have to teach hadith or Quran or work at a mosque. So there's just other parts of their lives. And with time, in the 9th and 10th century, only the very rich physicians are writing. So Al-Razi, Ibn Sina, Al-Majusi, these have amazing patrons. In the 13th and 14th century, so many physicians are writing, and they have like 3 jobs. And all these jobs come together. So you see a lot of religion and a lot of prophetic traditions coming in. Now, in terms of contradictions, the interesting thing is, by the time these physicians are writing, borrowing from the Quran and Hadith, the learned elites have been thoroughly Galenized. So they are using, there are prophetic traditions circulating where the prophet says the human body is made of 4 humors, and just describes them in the same way that Galen does. And now, these are not very trustworthy traditions, but nobody thinks of them as particularly dangerous because everybody believes it, right? So one of the things that I wrote about a long time ago is to trace the changes in interpretation of a verse that says, and that talks about the formation of milk in cows, and that we gave them clean milk between blood and feces. That's the, or between blood and dirty materials. And in the beginning, early on, the interpretation is it's really about, the breast. If you open the cow's teats, it will be very bloody. and there's the stomach that has the food, and that's it. It's a very physical kind of, thing. But then later on, it becomes deeply galenic of how the food is transformed into blood, and the blood is transformed into milk, and the left is removed outside the body. So by the time they are writing, the literature has been thoroughly galenized. So they are really not. There are hardly any contradictions, if you will. These same physicians are doing this autobiographical thing, but it's always about the idea of how they need to be pious and charitable in dealing with patients. So it's not about the patient's body or the diagnosis. It's about the poor patient and how medicine is ultimately a practice of charity. And so, how they will not take money from a poor patient, etc. And this crosses really the religious lines. So Maimonides is writing about this all the time. He writes about how he leaves the court of Saladin in the morning and goes to serve poor Jewish patients at night in Al Fustat, the suburb of Cairo. So this is the question of piety here becomes more social piety rather than one that's directly connected to a specific religion. Great. So to start, they don't know that girls hit puberty first. So they believe that boys hit puberty first. They firmly believe that. And but again, it is not. I mean, think about it this way: it is not without the intrusion of medicine into a person's life. Menarche is not a medically significant event to report, right? It is not. So it's not really. It can be significant in specific cases, but not significant enough that they can draw large conclusions. So they firmly believe that boys hit puberty first. But also puberty for them also means it's not just nocturnal emission or menarche. There is a lot of other things, including mental capacities. That's for them, this is the first and earliest sign, right? And in that case, they will swear that boys grow and are older and more mature earlier. So, yeah. Now, in terms of expertise of midwives, so I'm writing this other piece around an article about physical examination of women. And this is one of the areas where you see significant mentions of midwives, because they are clearly working with midwives, instructing them how to do, for example, what to look for in vaginal examination and to ask them about specific things. They do not have much, again, there is this kind of resistance of this expertise, which is on one hand because they are women, but it's also because they are one of these supporting medical professions that these physicians are not happy about at all. So they don't like herbalists either. They don't like bloodletters. They don't like anybody except learned physicians. And most certainly midwives for them are, if you don't ask them very specific questions and make them do very specific things, it becomes a problem. Now, what I'm seeing in the text and researching this article is that, for example, I'm focusing on Al-Hawi, which is a big collection of cases and clinical experience that Razi wrote, was collected posthumously. That there are moments when he's saying that he examined, when you examine a woman, you will find this and that. And I'm still figuring out whether this physical examination happens, that physicians themselves did this, particularly maybe to poorer women or to enslaved women, or that it's just by proxy the midwife will do it. And I still don't have an answer to that. On circumcision, it's not a physician's job. This is a surgeon's job, barber surgeon. So they don't do these circumcisions at all. Female circumcision is a very they never mention it because it's ultimately, it is considered, it's a practice that is in the writing learned elites. It's a practice that is not as common, and so they really never talk about it. And it is really a practice that happens, again, it's, as you mentioned, it's East African practice primarily. It's obviously in Egypt a lot, in Sudan, in Ethiopia, etc. And therefore they are talking about these people do these things. Many of them at the time, many of them are not Muslim, so they are not really concerned about this. But there is no legal instruction for female circumcision or genital mutilation at all. The legal requirement is only for male circumcision, and they don't do it. The barber surgeons do it, or sometimes the midwives do it at like immediately after birth. So they're not really talking much about it.